my favorite subjects to talk about. There's a lot in neuro, a lot of some of the strokes and some of the other acute presentations the symptoms can kind of run together and look very similar. And so we're going to talk about some ways to differentiate things from each other. Vertigo is another example where, a lot of the patients can tend to really present in very similar ways. And so we want to have really quick ways of differentiating between the different causes of things like vertigo so that we can, get to our answer pretty quickly. So we'll talk about that today and some other stuff. We're going to start off by talking about a 65-year-old man who is presenting to a neurologist complaining of resting tremor. So resting tremor, obviously, that's sort of a buzzword in itself. What is that? What are some of the first things that come to your mind with resting tremor? Parkinson's. Absolutely, definitely. That's what comes into my mind as well. That's probably the most common cause of resting tremor. So he's accompanied by his wife, who points out that her husband has been moving much more slowly, has not been sleeping well, has been depressed and anxious. During the interview, the patient speaks in a low tone without facial expression. His left hand has a resting tremor involving the fingers and wrist. Temperature is 98, heart rate's 90, blood pressure is a little bit elevated. What's our most likely diagnosis here? Parkinson's, right? Yeah, not too much changed from what we thought about initially. Some of these other symptoms, speaking in a low tone, there's this masked faces expression that patients have where there's really just a complete lack of an expression. And this idea of the resting tremor, whenever you see hand tremors, you want to really make sure that it is a resting tremor and not a intention tremor, because that's going to totally change your differential. So patients with resting tremor, if you ask them to reach out and grab something, that tremor is going to go away. Versus patients who have something like essential tremor, or patients who have something like asterisk that tremor is not going to go away when they attempt to reach for something and things like that. Okay, so that's going to be your main way of differentiating those disorders. But I agree with you, Parkinson's is definitely the most likely diagnosis. So on our physical exam, what do we expect to see? What are the common findings in Parkinson's disorder that weren't mentioned in the question stem here? Mm-hmm. 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 Yeah, you have that. Mm-hmm. Mm-hmm. Yep. So you mentioned the cogwheel rigidity. You mentioned the shuffling and fenestrating gait. And another thing that you can look for is these patients really don't move their arms when they walk. They're very stiff and they don't move their arms as they're walking around. And so for this patient, a physical exam reveals that wide-based shuffling gait without arm swing. Passive movement of the arms demonstrates uniform resistance to movement with a ratchet-like quality. Okay, and so while they're not intentionally resisting you while you're trying to move their arm, because of some of the issues that they're having, in the substantia nigra, loss of those dopaminergic neurons is why we see these changes. So Parkinson's disease, this is the most common of our bradykinetic disorders. It is idiopathic. We're not too sure what the cause is. However, it is characterized by that depletion of dopamine in the substantia nigra. And so every patient who has Parkinson's, on gross pathology, after an autopsy, what you would see is loss of these very dark neurons in the substantia nigra. Okay. So this is also characterized pathologically with these Lewy bodies, which are intraneuronal eosinophilic inclusions of alpha-synuclein. This is very step one type stuff, but still important to differentiate for step 2. You're going to see Lewy bodies as answer choices because they can try and trip you up between these Lewy bodies and the inclusions, the tau inclusions that you see in Alzheimer's. They can try and trip you up with Lewy body dementia, where you see really more of a neurological mind, sort of a loss of memory. The dementia plays a bigger role than in Parkinson's disease, but although there are still Lewy bodies. So symptoms, there's this Parkinson's triad, the resting tremor we saw in our patient, where there's a tremor at rest, but it goes away when they attempt to, do some task. The rigidity, cogwheel rigidity, due to these combined effects of rigidity as well as the tremor. Bradykinesia, where we have slow movements, difficulty initiating movements, that fenestrating gait without arm swing. And last is this postural instability. So these patients are going to be stooped, freezing. They may fall, just sort of mid-step, sort of attributable to that postural instability. So treatment, levodopa, carbidopa. These are both going to sort of replete the levels of dopamine in the central nervous system. You can also give other exogenous dopamine agonists, ropinirole, pramipexole, bromocriptine for the early disease. Selegiline, which is a MAO-B inhibitor. This blocks the breakdown of dopamine. This could be neuroprotective. It may decrease that need for levodopa. And then the COMT inhibitors increase the availability of levodopa in the brain. They may actually decrease motor fluctuations. So typically we'll give something like levodopa with one of the COMT inhibitors to increase levels of dopamine in the brain. Okay. Amantadine, this is an anti-flu drug. This also has mild anti-Parkinsonian activity, and really the only reason it's used anymore. Amantadine is not really used for the flu anymore. But it may be helpful for these patients with Parkinson's, improve that akinesia, rigidity, tremor. And if all this medical therapy fails, we can do a pallidotomy or deep brain stimulation to produce that benefit. Okay? All right, so in general, not too much that's different from what we needed to know for step 1. Really focusing in on the specifics of what you see clinically, I think would be the most beneficial thing for you. With this Parkinson's tetrad, they can just give you one of these things, they can give you all of these things, and expect you to know that they're talking about Parkinson's versus something like Huntington's, or another one of the motor dyskinesias. Okay. Great. So, moving... But yeah, so Parkinson's disease, in general, a lot of stuff that we needed to know from step 1. We're not really adding too much here. What I mentioned before is just that you really want to sort of hone in on these symptoms and be really comfortable, even if they give you one of these symptoms or all of them, with what to do in terms of treatment. Okay? All right. So we are going to go on here to our next case. We have a 50-year-old left-hand dominant man who presents to his primary care physician with complaints of right hand weakness. Okay, so what do we think when we think of right hand, or just, single part of our body suddenly becoming weak? Stroke? Yep, just involving one part of that motor cortex, a lesion in the motor cortex. I like it. Good. So he says 6 months ago he began dropping things with his right hand. In the subsequent months, his grip strength has weakened further. His handwriting has deteriorated. He's also noted frequent twitching of the muscles in his right hand, forearm, and shoulder. Has developed painful muscle cramps in his neck and back. He also reports occasional problems swallowing food and says his speech seems thicker. Okay. So this patient reports no other significant past medical history and denies lower extremity disturbances or sensory deficits. Vital signs are within normal limits. Cranial nerve exam is significant for atrophy of the tongue, which also demonstrates fasciculations upon protrusion. On motor exam, the patient has significant thenar atrophy of the right hand, but not on the left. Strength is diminished. Tricep strength is diminished. Neuromuscular exam of the lower extremities is normal. Reflexes are 3+ in the upper extremities bilaterally, and he has a brisk jaw jerk reflex. Is 3+ normal? 3+ reflexes? No, it's a sort of exaggerated, right? This is, yeah, hyperreflexive. Excellent. Sensory exam is normal. Patient's gait is normal. He exhibits no ataxia. So, most likely diagnosis, or at least a differential of things that we should start to look for. Upper motor nerve, yep. ALS, right? Excellent. Very good. Yeah. Yeah. Yeah, good. Well, anytime you thought about this in exactly the right way, I have to tell you, Daphne, anytime you see upper motor neuron with lower motor neuron, you need to be thinking about ALS. That should just jump straight to the top of your differential. And then when you start to see things like sensory exam is normal, okay, if sensory exam is normal, that's really going to rule out anything that's, maybe some sort of stroke in the internal capsule, or any of these other disorders where you're having upper and lower motor neuron signs. You would have sensory with it. Because sensory is normal with ALS, that really points you in the direction of that particular diagnosis. Okay, excellent, very good. So amyotrophic lateral sclerosis, progressive degenerative disease characterized by loss of upper and lower motor neurons. Whenever you see they're really trying to gift you this question. So know all the details about it, because that is really a gift. Males, more common than females. Onset, in sort of middle age to geriatric population. This is going to be asymmetric. That's the first thing. Just like in the patient in our question stem, we saw right hand thenar atrophy, but the left hand was fine. Slowly progressive weakness over months to years, affecting the arms, legs, diaphragm. Look for that patient with upper motor and lower, like you did. Tongue atrophy and fasciculation is often described, okay? And so, when they start to go from, seeing these signs that are in the extremities, and then they start talking about bulbar signs like this tongue atrophy, difficulty swallowing. This patient said his speech sounds thicker, so slurring of the speech, not able to control your tongue. These signs are also typical of ALS, and so we should keep an eye out for that. 25% of patients initially present with bulbar symptoms, slurred speech, difficulty swallowing. Great. So diagnosis is really going to be on clinical presentation. This is just such a specific description that it's pretty easy to, or not easy, but it's definitely one of those things that you can diagnose clinically. Another thing that you can look for is the cervical MRI. And so with some of the conditions where you have some impingement of the cervical spinal cord, you could see the similar signs as amyotrophic lateral sclerosis. However, these patients will have a negative cervical MRI. You will not be able to see any pathology in the cervical spinal cord, and that also points you in the direction of ALS. If you wanted to really confirm this diagnosis, you could do an EMG, which would show widespread denervation of muscles, some fibrillation potentials in those nerves, and that could point you in the direction as well. The treatment here is really going to be supportive, although recently, in the books, they've been describing this drug called riluzole. This is an NDMA antagonist, and so far it's been shown to improve survival in these patients with ALS and increase the time before the ventilator is required. Okay, and so that is really the goal in treatment of patients with ALS, is to keep them off the ventilator. Respiratory failure is going to be the most common cause of death in patients with ALS, and so that's really going to be the goal, is to keep them off the ventilator. So here we can see what tongue atrophy looks like. You can see that the tongue is not, uniformly thick, that there's areas of thinning in the tongue, and so that is going to be typical for this tongue atrophy, those bulbar signs, involvement of the hypoglossal nerve. And then we have here a slice of our cervical spinal cord. And some of the questions on step 2 are going to expect you to be able to figure out which areas are going to be involved with all these different pathologies. And so I'm just going to kind of label these areas. So this is going to be A, we'll have B here, this is going to be C, this is going to be D, and this will be E. Okay, and so which areas would you select in terms of where the lesion is in patients with ALS? And you're allowed to choose more than one. D, excellent. Good. So that would be our lower motor nerves, right? Because that's where those cell bodies are. But we have upper motor neuron and lower motor neuron deficits. So, in what area would we see damage to those upper motor neurons, to those axons coming down from the motor cortex? So anytime you're just having axons, it's got to be in the white matter areas. So B is going to be our cell bodies for the spinal cortical system. So pain, itch, and temperature. You'll see those cell bodies there. So it's not going to be B because these are all nerve bodies. It's got to be either A or C. C. Excellent. Good. So this is going to be our lateral pathway, and this is carrying all of our axons from the motor cortex all the way down. These axons will enter and synapse on our lower motor neuron. That lower motor neuron will go on and innervate, part of our body. Okay, and so when we have damage or destruction to part of our lateral pathway, as well as the lower motor neuron, that's going to give us our upper and lower motor neuron signs, depending on where in the body it is. This is asymmetric. Each part of the body is going to be affected at a little bit of a different time. Okay. A is going to be carrying all of our proprioception, fine touch. This is the dorsal column, and so that's what we would expect to see there. Okay, great. Oh, yep, so I had the little things flying there for you. Yep, so those are all the areas that we could see affected. Obviously, they're not all going to be affected simultaneously. Otherwise, this would not be an asymmetric disorder. It would be on one side or the other. And so the other thing is with these disorders, if they're, saying that it's right hand, you want to make sure that you're selecting a lesion that would be on the right side of the body. So that should be on this side. If it's on the left hand, it would be on the left side of the body. Because there's no more crossing over or decussation that happens at this point, it would all be ipsilateral. Okay. It is, yeah. And, I think I'll add for our next lecture sort of a talk about all of the different pathways just as a review. It's, nothing's changed from step 1, but it's good to have that sort of review because they can ask you when it comes to like Brown-Séquard syndrome, where you have a hemisection of the spinal cord and then you have sensory loss on one side and motor on the other. It's a good review to kind of have those things fresh in your mind, where these pathways are, where do they decussate, and what is that going to result in terms of clinical presentation. So we'll talk about that on Friday when we meet. Okay, so anytime we have, so this is just sort of your general presentation of an ALS patient. A 55-year-old male presents with slowly progressive weakness in the left upper extremity and later in the right, associated with fasciculations, without bladder disturbance, and with a normal cervical MRI, we think ALS. Okay, this is just sort of, really all you need to change here is the age, what extremity it is, and you basically already have your question stem, okay? So the things they're going to ask you where in the spinal cord is the problem, what is the treatment, and you're going to select riluzole. It's an NDMA antagonist, yeah, that's really, there's not too much more they can ask you, okay? Slowly progressive course, yep, very good. Okay, so differential diagnosis of neuromuscular weaknesses. We have a number of different disorders of ascending paralysis, descending paralysis. What are some of the other things that can cause paralysis, be it ascending or descending, symmetric or asymmetric? Just some of the other things that could go on a differential. Mm-hmm. Mm-hmm. Oh, good. Hemisection, yep. Guillain-Barré, yes. Excellent. Mm-hmm. Mm-hmm. Strokes, definitely. And polio, which you mentioned before. Mm-hmm. Yeah, good. So that's really most of them. ALS we talked about, Guillain-Barré. So Guillain-Barré is going to be a ascending paralysis rather than descending. So it's going to kind of start in the extremities and then ascend. Multiple sclerosis will affect different areas of the body at different times. Look for people, a patient with, a history of blurry vision when they're hopping out of the shower and things like that. For whatever reason, hot water makes it worse. And so that's common in multiple sclerosis. Myasthenic syndrome as well as myasthenia gravis. You have that disorder of the neuromuscular junction that results in weakness. Lambert-Eaton syndrome, and so this is a paraneoplastic syndrome, right? This is associated with certain types of lung cancer. A small cell, I believe, is the one that pops to my mind. And in this syndrome, we form antibodies to the presynaptic calcium channels. Okay, antibodies to the presynaptic calcium channels. Those calcium channels are very important for allowing for synthesis and release of all the neurotransmitters from that presynaptic terminal into the synapse. When you have those antibodies formed to those calcium channels, you're going to block or destroy those calcium channels. Now you have all these vesicles full of neurotransmitters that can't actually fuse with that membrane and release the neurotransmitters out. Okay, so that results in sort of that NMJ weakness as well. Okay, excellent. Okay, so our next case here, we have a 18-year-old man who is brought to the emergency department by his mother for increasing sleepiness. His mother relates that he has been having fevers for the past week up to 101, which were reduced with Tylenol. The last 2 days he has had headaches, and this morning he has been experiencing significant nausea and vomiting. Not good. She attributed these symptoms to gastroenteritis until he began having trouble using his left arm and became progressively more somnolent. He has no sick contacts, but did have an upper respiratory tract infection about 5 weeks ago. His past medical history is significant for mild asthma and frequent sinusitis. Okay. His sinusitis usually resolves with oxymetazoline and saline nasal sprays. Several times over the past few years, he's required antibiotics for chronic sinusitis. On physical exam, the patient can answer some basic questions, but has difficulty keeping his eyes open. His neck is supple. His neurologic exam demonstrates bilateral papilledema and 2 out of 5 strength in his left arm and leg. Okay, and so most likely diagnosis. This is a tricky one. So definitely we're thinking about something infectious. Because of, this rise in this, he's been having temperatures and, he's got this history of sinusitis. The sinuses are right there next to the dura. So we want to think about maybe an infection that is involving the dura. It could have gone beyond that. If we take out that sinusitis piece, I would really just think of a patient with some sort of intracerebral abscess, right? Mm-hmm. 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 Yeah, definitely. Yeah. So, you can see the abscess. When you talk about the sinusitis piece, that they just spent so much time talking about that. You have to somehow involve that, and so the sinuses are right next to the dura, so you think more of a dural abscess versus a intracerebral abscess. The last thing that could come to mind with this age group, high fevers, you could possibly think of a meningitis. although this presentation is not really typical for meningitis. You usually don't see focal neurological signs like decreased strength in certain areas of the body with meningitis. This patient's neck is supple, meaning there's not rigidity when we try and bend the neck, right? With our Koenig and Brzezinski's sign. So, long story short, really the highest things on our differential should be intracerebral abscess and our dural abscess. All right, so next best step. CT. I like it, yeah. So, what would you expect to see on CT? Left arm and leg. Good. So, yeah, absolutely, I agree. And I also, the other thing that you want to look for is he also having, sorry, go ahead. Edema, yeah. So, is there that edema, and is he also, is this progressing from a sinus? So you want to really look at all those sinuses and see if there's, a focus of infection that may need to be drained. Okay. So great. So sorry, go ahead. Yeah, so you could see basically involvement of the bone. And so what they're describing here, they can say it better than I can, which is why I'm reading from this. So a ring-enhancing lesion adjacent to the superior aspect of the right frontal and temporal bones. So you're going to focus in on all of the different sinuses. So you have your maxillary sinuses, your ethmoid sinuses, you have, you basically you're going to evaluate all of the different sinuses, and you're going to look for, does one of these sinuses look more dense? And then is one of these sinuses nearby where your dural abscess is? And that should kind of point you in the direction of the diagnosis. Okay. Yeah, so, yeah, you could, because usually it only goes down to the maxilla. That's why you're saying that? Yeah. Yeah. Yeah, no, Daphne, that's an excellent point. When you order a CT, if you do CT brain, you're not going to get a great view of the maxillary sinuses. You're not going to get a great view of, some of the other sinuses as well. And so you definitely want to order 2 CTs. That's an excellent point. Yeah, I didn't mention that, but that's an excellent point. Yeah. So lab findings, we do see a white count. Red blood cells and platelets are relatively normal. And then this is not our patient, but just sort of a image that I could find online. Dural abscess images are kind of hard to come by, but here we can see, this is an MRI, but you can see some of the spinal cord coming down here, and then right outside the spinal cord, sort of encapsulated, is this little dark area that's surrounded by a lucency, and so this would represent a dural abscess in the spinal cord. Okay, but obviously for our patient it would look a little bit different. All right. So epidural abscess, we look for a headache, nausea, vomiting, and focal neurologic deficits. Most commonly, we're looking for just the regular nasopharyngeal flora. So strep pneumo, moraxella, Haemophilus influenzae, not type B, but the non-typable strains. Having a patient with a history of sinusitis is quite common. If you sort of block the drainage pathways for these sinuses, you're going to end up with overgrowth of those bacteria. That's going to manifest as an acute sinusitis. Those bacteria now, instead of coming out, they can go up and start to break down the bone around the sinus and then go into the brain. Spread of this infection is usually going to occur via thrombophlebitis. And so all of those draining diploic veins that are in the cranial bone, all of those veins are going to be involved here. They're going to start to clot. The bacteria are going to grow upwards and continue to progress eventually to the dura. This is sort of a valveless system here with those diploic veins, and so the bacteria are going to be able to continue progressing until they get to the dura. Peak incidence of these epidural abscesses is going to really occur in adolescence, and it's more common in males. This has to do with the vascularity, actually, of the cranial bone. And so if you have patients in adolescence, we sort of have the highest density of these diploic veins. It's more vascular than it is at any time of our life, and for whatever reason, it's more vascular in males, so we end up seeing it more common in this population. After we do identify that lesion via CT, we need a neurosurge consult for the next best step. We're going to need to start antibiotics, surgically manage this intracranial abscess in order to have a positive outcome. Okay. All right. Any questions on epidural abscess? Mm-hmm. 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 So, I mean, I think that there are a few ways they can ask you about this. Number one, I actually think that knowing that the organisms involved are the normal flora, your typical strep pneumo, moraxella, things like that, that could be a question where they're kind of going after the microbiology of it. Is this something invasive like a rhizopus, mucor, those things that we see in diabetics? No, this is just the regular flora. Okay, and so that's sort of an important concept, and it kind of gets after what is our antibiotic, what antibiotics are we going to want to use. Okay, so that's one way they can go about it. Another way they can go about it is giving you the patient history and sort of asking you what would be the next step in terms of imaging. Obviously, CT is going to be great, so that would be an easy question. In terms of next best step, once you've identified it, you're right. You're never really going to see like consult neurosurgery as an answer choice on step 2. You need to have an understanding that this patient needs sort of that immediate antibiotics, and this abscess is going to need to be drained. Okay, and so that's basically what neurosurgery is going to do. They're going to go in and drain it if it's easily accessible. Okay, otherwise, if it's somewhere in some of the deeper dura, sort of, a little bit deeper in the brain, it may be more difficult to get to, and so neurosurgery may want to use strictly antibiotics, but this is really getting into, a little bit more advanced stuff than we need to understand for our current level of training, and so that's definitely too advanced. Really just knowing that the goal here is to reduce the bacterial load and then eventually drain it if it's accessible would be our goals. Okay. The other thing we'll have to do is drain that sinus, right? Because that's sort of the nidus of infection here, and that's pretty easily accessible. Okay, if it's like a maxillary sinus or something like that. Okay. Great. Okay, and so we have a question here. Daphne, if you want to read through this question and let me know what you think the next best step would be. Or I can also read it if it's blurry. Yeah, no problem. No problem. So we have a 43-year-old male who's presenting to the ED with a complaint of a headache. This headache developed acutely over the past few hours, is severe in nature. Pain is located bilaterally on top of his head without radiation. He denies any associated weakness, denies double vision, nausea, vomiting, dizziness, none of that. Denies phonophobia or photophobia, has no prior history of headaches. Vitals, his blood pressure is elevated at 144/90. His examination is a middle-aged man in distress related to pain. Neuro exam is negative for focal weaknesses or sensory deficit. No nuchal rigidity. Cranial nerves are intact. CT brain without contrast is obtained and is negative for ischemia or hemorrhage. What is the most appropriate intervention? And our options here. Sumatriptan. We can go get an MRI if we're not happy with our CT. Cerebral angiogram, CT brain with contrast, or a lumbar puncture. So just going over some of the important points from this vignette. It's an acute development of pain. He does not have any weakness. He does not have phonophobia. He really doesn't have a lot of signs of meningitis. No nuchal rigidity. Cranial nerves are intact. And then on CT, we don't see any ischemia or hemorrhage. Great. Great. Yep. CT brain with contrast wouldn't be a great step. The other thing about, these subarachnoid hemorrhages, if it's a very small aneurysm, it may be hard to see on your CT. Okay. And so the best next step in terms of identifying, looking for those red blood cells, if we think it's a subarachnoid hemorrhage, would be that lumbar puncture. Okay. All right. And so things that point us in that direction of a subarachnoid hemorrhage would be this elevated blood pressure, the acute presentation of the headache. If it's an acute presentation of headache and it's something related to vascularity, obviously, especially when it's severe in nature, that really makes us think of a subarachnoid hemorrhage, right? That's our thunderclap headache. All right. Now that it's step 2, they're not going to use the words thunderclap anymore, right? I said that when you have this acute headache that's severe in nature, that really makes you think of that thunderclap headache of subarachnoid hemorrhage. And because this is step 2, they're not going to say thunderclap headache, right? We're kind of beyond that point, that they want you to really be able to identify it other ways, and so this would be the way that they expect you to identify it. Okay. All right, great. Okay, great. So next we have a 78-year-old woman found by her son lying at the bottom of the stairs in their house where they live together. After calling for an ambulance, the patient is brought to the emergency department for further evaluation. The son is not sure how long his mother was at the bottom of the stairs, but suspects that she must have fallen while attempting to descend the stairs. He states that she does not smoke or drink and that she is fairly healthy except for a history of hypertension, for which she takes atenolol, and hip arthritis, for which she takes ibuprofen. The patient is responsive but confused. Painful stimulation of the right lower and upper extremities elicits movement, whereas painful stimulation of the left produces no response. A Babinski reflex test elicits downgoing tests on the right and upgoing toes on the left. Vital signs include a temperature of 98.4, heart rate of 90, and respiratory rate of 16, blood pressure 135 or 75. CBC and blood chemistry are within normal limits. So what's our most likely diagnosis here, or at least a differential of things we can start to evaluate for? Stroke, okay. So stroke for sure. There's one more thing that I want you to say. We have an older woman here who has some sort of trauma, right? Not a serious trauma, but maybe a mild trauma. What is something else that we could be concerned about? Abuse, yep, abuse. But in terms of what is actually happening, so if it wasn't a stroke, what would be another cause for this particular presentation? Not a stroke. Yes, excellent. So this would be our subdural hematoma is the other option here. Okay. not epidural, because for epidural hematoma, we really need a lot of force and a lot of trauma directly to the temporal bone. Maybe somebody getting hit with a bat or car accident, something like that. This is just sort of a fall down the stairs, and so we wouldn't think of an epidural hematoma, but subdural could definitely go in our differential for this particular presentation. Okay, although strokes, I agree with you, seems pretty likely as well. Could have been the cause of the fall. She could have had a stroke and then fell down the stairs. It's hard to really differentiate and determine what exactly happened from this particular presentation without getting any imaging. So, what would be our next best step? CT. Excellent. And what would we expect to see on CT? So really, depending on what the diagnosis is, I think it's kind of unfair to expect you to determine whether it's a stroke or subdural hematoma from this particular presentation. This presentation is going to be a subdural hematoma, but you're absolutely right. This could be a stroke as well. And I should have given you a picture of the CT so that you could really evaluate, because if you can't see that crescent of blood around one side of the brain, it's really hard to determine what exactly the cause is. This could just as likely be a stroke. Okay, and so that's kind of on me. That's kind of on me. But it would be between those two, right? Yeah. Okay, great. So subdural hematoma, essentially this is just that collection of blood between the dura mater and the arachnoid membrane. This typically occurs following some sort of head trauma, a fall, an assault that's going to lead to rupture of those bridging veins, right? This is definitely step one type stuff, but coming back again, this leads to accumulation of blood in that area. This is going to present with a headache, changes in mental status, contralateral hemiparesis. Okay, so collect all of that blood collection. This is sort of where we're going from step one to step two. As that blood is collecting on one side of the brain, we may have shifts of all of the gray matter in the opposite direction. Okay, and so these changes may be subacute or chronic. Most patients do not immediately become unconscious. Okay, and that's sort of one of the other big differences between a subdural and a epidural hematoma is that with the epidural hematoma, you have that lucency period, and then after that, patients become unconscious. With subdural hematoma, it may be a few days, it may be a few hours, maybe a few days, maybe a few weeks before patients actually lose consciousness. The symptoms that we do see are associated with that increased intracranial pressure, compression of the brain parenchyma. If we have a subdural hematoma on the right side, we would expect to see focal weaknesses on the left, right? It's contralateral. And so that's sort of one of the areas that they can kind of ask questions about. That mass effect can also result in that ipsilateral dilated non-reactive pupil, contralateral hemiparesis, papilledema, cranial nerve 6 palsy. So in terms of talking about some of these cranial nerves, we really tend to see the manifestations on the same side. Whether you're talking about, your cranial nerve 3 for this non-reactive pupil, cranial nerve 6 for that trochlear nerve, abducens nerve, or if you're talking about maybe something involving a facial nerve in a different disorder, it's really going to be ipsilateral compared to all of your extremity weakness, which we would see contralateral. Okay. If you have a very slow bleed that's been happening over weeks, you may actually have this patient presenting with a pseudo-dementia, where these patients have a lot of those symptoms of dementia and may go undiagnosed. This hematoma may go undiagnosed until we have an actual uncal herniation, right? And then we have severe big problem. Okay, and so when you have an elderly patient, you really want to make sure that you evaluate for any history of falls. Even if they drop that nugget in the question stem as, the patient had a fall, 3 weeks ago, but did not have any symptoms after that. Okay, fine. No symptoms after that, but did that start a bleed that, because it's coming from a vein, is a very slow bleed into the subdural space that's now accumulating? On CT, we're used to seeing what this looks like, that hyperdense crescentic mass that does not cross the midline. It should be really just localized to one side of the brain. If these patients are symptomatic, we can do a surgical evacuation. But small asymptomatic bleeds, these would be slowly resorbed. So a lot of patients that have a fall will automatically get a CT scan. If you identify a subdural on a CT scan, but your patient's asymptomatic and it's not a lot of blood, you may just sort of watch and wait and with close follow-up. Some of our high yield points here, we're looking for that history of head trauma, diminished consciousness, some focal neurologic deficits with the CT findings, which I didn't give you, which makes it a lot harder to diagnose if you don't have those CT findings, right? Great. In terms of differentiating from that epidural hematoma, we really need a tremendous force to the temporal bone. And the presentation really goes in this triphasic way. So we get a brief loss of consciousness, followed by a lucid interval lasting minutes to hours. Okay, so patients lose consciousness, and then they come back and sort of are relatively normal. They then start to develop this headache, progressive obtundation, and hemiparesis. Eventually, we can get that blown pupil, secondary to uncal herniation. Okay, and that's a big problem once you have that uncal herniation. Okay. Any questions on subdural? So this is an arterial bleed, so it'll be within hours. It'll be within hours. Yeah. Mhm. 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 Absolutely. I agree with you 100%. This patient, like you said, they don't want to be seen. They seem totally normal. Then they are slowly getting progressively confused, obtunded, and hopefully you catch them at that point. But if not, they're just going to be unconscious in their bed. And then you do your exam of the pupils and you see one of them is totally dilated and fixed. And then that is sort of your sign that uncal herniation may have already happened. Okay. Yeah. And so, with this blown pupil, which cranial nerve is it that gets compressed during that uncal herniation? What causes that blown pupil? 3. Excellent. Yep. Okay. Okay, great. Case 5. We have a 53-year-old woman who presents to her primary care physician complaining of severe nausea and dizziness. The patient's symptoms begin upon arising from bed. She states it feels like the world is spinning around her and that she feels nauseous. Sitting still for a moment will cause the symptoms to abate, but upon moving again, the symptoms begin again. The patient has no significant past medical history, is an avid runner, denies any history of smoking, alcohol use, recent illnesses, sick contacts. Vital signs are stable, and results of the laboratory tests are within normal limits. And so, what does our differential diagnosis here consist of? Something related to the ear? Yeah, definitely. Whoa. Okay. Okay, no problem. We're gonna fix that right now. So definitely some sort of vestibular problem. Okay, so when it comes to problems of the ear, all of our vestibular problems, we can have problems in our central nervous system. So we can have problems in our brain. This would be like a central vertigo. Okay, central vertigo. If we have some sort of stroke involving the vestibular nucleus and the medulla, loses blood supply, that could lead to a central vertigo. Any problem with the tracts anywhere from the ear all the way to the vestibular nucleus, anything in that area can cause a central vertigo. Okay, and that would be sort of a problem that is not related to position, because the stroke is involving that nucleus. You can consider that nucleus is no longer functioning, and so for one side of this patient, they're just constantly going to have this sensation of spinning. Whether they're lying down, sitting up, it's not going to make a difference. Okay. For our patient, it seems like whenever she moves, that's when she has the problem, right? When she sits still for a moment, the symptoms abate. And so we can say that it's probably not a central vertigo. We can say that this is probably going to be a peripheral vertigo. And so peripheral vertigo is anything involving the semilunar canals, any part of the ear, any part of the vestibular nerve. So as the nerve is leaving through the external auditory canal, through the internal auditory canal, if you have some sort of schwannoma there, right? Our patients with neurofibromatosis type 2 end up developing schwannomas right there as the nerve comes out. That could lead to a peripheral vertigo, okay? And so those are going to tend to be related to movement in general, okay? And so for this, sorry, go ahead. In general, so not all of them. That's not a good way to differentiate central and peripheral. If it is related to movement, you know it's not central. You can say it's not central if it is related to movement, but there are some peripheral vertigo that will be present at rest. So our Meniere's disease, which is related to that increase of pressure in the endolymph, having a tumor on the auditory nerve, on the vestibular nerve, would lead to symptoms, at rest as well. So I kind of said that, but I immediately wanted to take it back. You cannot sort of differentiate both of those just by whether it's present at rest. But you can tell it's definitely not central if the symptoms abate at rest. Okay? It's definitely not central. It's definitely peripheral. However, there's still some differentiation that you have to do in terms of what type of peripheral vertigo it is. Okay. So, a particular maneuver that we can do in terms of diagnosing the vertigo, one of the maneuvers is called the Dix-Hallpike test. And so the Dix-Hallpike test, what we do is we take the patient from sitting and then quickly have them lie down and then rotate their head 45 degrees. If this maneuver produces the symptoms, you have your diagnosis. Okay, if it reproduces the symptoms and causes upbeat nystagmus, you have your diagnosis. This is going to be BPPV, benign paroxysmal peripheral vertigo. Okay, and if this does not produce your diagnosis, then you can go on to look at other types of vertigo. Your Meniere's disease, your labyrinthitis. We're going to go through all the different diagnoses for vertigo. We have a slide for that. But with this particular test, if they describe the Dix-Hallpike maneuver for you and you see nystagmus, you have your diagnosis. There's really nothing else that you need to do. Okay. And so the trouble with a lot of these different causes of vertigo is they're very difficult to diagnose. And so when it comes to things like Meniere's disease, that's going to be diagnosed by the history in the clinical presentation. There's not like one test you can do like an MRI and you know it's Meniere's disease. The nice thing about BPPV, the reason I made it a case, is because you have this maneuver that you can do to diagnose it, right? And so that's sort of the benefit there. So BPPV, most common cause of peripheral vertigo. About 50% of cases are BPPV. Again, we said peripheral vertigo are some sort of lesion in the semicircular canal or vestibular nerve. Our central vertigo is going to be a lesion of the vestibular nuclei. So our Wallenberg syndrome, which is our lateral medullary syndrome, where we lose blood supply from the pica, results in a Wallenberg syndrome where we see sort of hemisensory loss on one side of the body and then hemiparesthesia on the other. We're going to talk about all of those when we meet on Friday, but one of these symptoms of Wallenberg syndrome is this central vertigo. BPPV, in terms of the pathogenesis, it's thought to be caused by dislodgement of some calcium carbonate crystals called autoconia from the autolytic membrane of the utricle, which then travel into the semicircular canal ducts. This is called canalithiasis. This debris in the canal is going to cause inappropriate endolymph movement. The sensation of rotational movement is out of sync with the actual movement. Basically, we have a foreign body in these canals that's sort of shifting around all the fluid and making our patient feel like they're spinning when they're really sitting still. Okay. the symptoms of BPPV. In terms of symptomology, this is going to be your way of diagnosing different types of vertigo as well. The length of the episode of vertigo is going to point you in the direction of the diagnosis. So with BPPV, we have acute episodes that last less than a minute. Okay, just quick sensation of vertigo and it goes away. So these episodes are going to occur sporadically, triggered by sudden head movements, and some of these patients may experience nausea and vomiting, but that's a very small part of this clinical picture because it's such a quick episode of vertigo. So typically these patients are not going to report nausea and vomiting. Okay, another thing that's going to help us in terms of our differential, these patients, if they report nausea and vomiting, it's going to be very small, or it's going to be sort of a new thing that they didn't have before. It's really a very small part of the clinical presentation, right? Seeing nystagmus in the Dix-Hallpike maneuver is pathognomonic for BPPV. That's all you need for diagnosis, right? Do that Dix-Hallpike maneuver and you have your diagnosis. While your patient is still down there, you can do something called the Epley maneuver, where you shift the head basically 275 degrees, and you do that rapidly, and that basically moves out autoconia from the semicircular canals. You may need to do it a couple of times to really get all of that autoconia out of there, but it has about 80% success rate for treating benign positional paroxysmal vertigo. Your patient's not going to have vertigo anymore after that, which is pretty great. But even if you don't do the Epley maneuver, moving the head 275 degrees makes you nervous, makes me nervous too. Even without that, this tends to resolve within weeks. Okay, that autoconia is going to just sort of eventually filter down and stop causing problems. One important thing for the step 2 exam is that in general, meclizine, our classic anti-vertigo medication, is going to be contraindicated. The reason for this is that we want our elderly patients to have some ability to compensate for the vertigo. These are very quick episodes, and we have one normal semicircular canal on one side and one abnormal on the other side. We want our patients to be able to sort of compensate for this feeling of vertigo. If you give meclizine, you kind of take away their compensatory ability. You may end up having more falls, actually. Okay, and so in general, we don't want to give meclizine for these patients. What we'd like to do is do that Epley maneuver or just sort of wait and see. All right, and so that is a good answer for step 2. If you have this patient in clinic, they're going to want some kind of medication, so that's going to be a different kind of struggle. But for the step 2, don't give it. Okay, so differential diagnosis of vertigo, again, BPPV, paroxysmal, comes and goes. Some nausea, vomiting, not a big part of the clinical picture. We're going to confirm it with the Dix-Hallpike test and treat it with the Epley maneuver. Our Meniere's disease, here we have vertigo and auditory symptoms. That can be ringing in the ears. That can be hearing loss. That can be a sensation of fullness in the ear is commonly described. A patient with vertigo, hearing loss, and the sensation of fullness in their ear. So that's our Meniere's disease. Here, these patients are frequently going to have nausea and vomiting. Why? These symptoms last for days. It's thought to be due to changes in the barometric pressure. So as you have a giant weather front moving into your town, now your patient is going to be having all of this vertigo and auditory symptoms for the duration of the time that this barometric pressure is low. Okay. The treatment has gone through different evolutions through the years. Originally, it was treated with a low-sat diet and diuretics. It was thought to decrease the pressure in the ear, and so you may see that as an option choice, although really clinicians have gone away from it. Now they really treat it with anti-migraine meds. Okay, so things like sumatriptan and some of the other anti-migraine medications are where we go nowadays. So syncope can also result in vertigo but here, obviously that would have also loss of consciousness, secondary to decreased cerebral perfusion. These patients are going to have that prodrome of dizziness and weakness. They'll sort of feel it coming on. Any patient that syncopizes, any patient that passes out needs to be on Holter monitor. They should get an ECG, and we need to check their cardiac enzymes. And so that will be able to rule out any sort of cardiogenic cause. We can do a tilt table test to look at what their ability to compensate for low blood pressure is, okay, and see if that's sort of their cause of loss of consciousness is because of a drop of blood pressure. Vestibular migraines. Here we have recurrent dizziness and vertigo, typically without auditory signs. Okay, dizziness, vertigo, no auditory signs. This is going to be in patients that already have a migraine disorder. In fact, about 10% of patients that have a migraine disorder will present with vestibular migraines. So these patients are already getting these migraines, and now the migraine is going to involve their vestibular system. These patients will have nausea. They'll have vomiting. They already get migraines, so photophobia is to be expected. Our job as clinicians, we want to rule out transient ischemic attacks, and we're going to treat this with anti-migraine meds because it's a migraine that's involving the vestibular system, and so migraine meds are going to be our go-to. Okay. Our last cause of vertigo is this acute peripheral vestibulopathy, aka labyrinthitis is probably what you've heard before. You may have heard vestibular neuritis. Here we have acute onset vertigo and gait unsteadiness with auditory symptoms. Okay, acute onset with those auditory symptoms. Here we have an abnormal vestibular ocular reflex. What this is another test kind of like the Dix-Hallpike, except in this one, what we do is we have the patient sit across from us and then rapidly turn their head side to side while looking at us. Okay, so we tell your patient, turn your head side to side but stare at my nose. And as they start to do that, and then you ask them to stop, you're going to see their eyes continue to move. You'll see nystagmus. Okay, that's the vestibular ocular reflex. And an abnormal vestibular ocular reflex is when you continue to see nystagmus. And you or me, if we did that test, as soon as we stopped moving our head side to side, our eyes wouldn't continue moving side to side. So that's the abnormal reflex. We would get an MRI in these patients to look at the vestibular nerve. In our treatment strategy here, we're going to give steroids to reduce the inflammation of that vestibular nerve, and we could also give meclizine to reduce the symptoms until the inflammation goes down. Okay? All right. Does that kind of help in terms of sort of breaking all of these different causes of vertigo down? No, Daphne, I feel the same way. I'm not sure the way that they teach it in medical school or what, but I was always kind of confused by it too. Really, the most important differentiating thing that you need to be able to do is between BPPV and Meniere's. That is really, as long as you can differentiate between those, which is actually not hard to do. I mean, Meniere's, yeah, you have vertigo, but you also have these loss of hearing, right? You have ringing in the ears. That is not a part of BPPV. And it never will be a part of BPPV because it involves the semicircular canals or semilunar canals, whatever they are, and it doesn't involve the auditory system. Okay, so seeing that really helps. Sure. That's correct. Yes, the Epley maneuver, essentially, when we have our patients lying down, like in that image I showed you, we turn their head all the way as far as we can to one side and then rapidly turn it to the other side. Okay, this is like the most chiropractor thing that we do as doctors, right? This would make me uncomfortable, to be honest, but we turn it as far as we can to one side and then rapidly turn it to the other side. And what we're doing is we are shifting all of the material, all the endolymph, and hopefully knocking that otolith out of the way. And so, yes, you're right. That would be curative. If it works, that would be curative. And, they say it works 80% of the time. So it's a pretty good treatment. And these patients won't need medication. Okay. Great. All right. So that will be it for today. When we meet on Friday, we're going to do a quick question. And we have more cases to do together. Awesome. Okay, great. Well, have a great day. And